All right. Well, welcome. Sorry, I'm not able to see everybody that is on, but it looks like we got lots of folks on. Woohoo! We've got our new clinics. Yay! Um, so I thought we could go ahead and just give you a quick update, get started on some of the things that are happening. And first, I just want to say welcome. We have our new clinics on, and so we've got Terry on. Thank you. And I was just talking to Dr. Martin, so yay. Um, just one of our big updates is we will actually be onboarding 2 new sites for the CoCM program. You probably heard us talking about this, but it is actually happening now, and we're really excited. We are onboarding McGee, and I know Terry is on with us, and we will be there on Thursday next week, and we'll be onboarding River Valley Medical Wellness on Wednesday. And so part of that will include bringing in the Woven doctors who are now licensed in Arkansas. They're going to be the psychiatric consultants who are working with both of these organizations. And so we're really excited about that. And Terry, I'm going to ask if you have any comments or thoughts or things that you want to share about the upcoming visit.
And it might be good to have some introductions of the new folks and the purpose of this meeting overall, Kim.
Yeah, last month we actually had them do a brief presentation on their organizations. And so, but that's a great idea. For folks that weren't on last month, we have Terry Amstutz, and he is with McGee Family Practice in McGee, Arkansas. And they are actually a rural health center connected to the McGee Hospital. So I don't think I did that justice, but Terry, I'd love you if you want to just add to that. That would be awesome.
You might be multitasking.
No worries. But just so you know, we will be going down there next week, onboarding them, and they're really excited. One of the things they talk about in that area in particular, which is down in the Delta, is they are really having difficulty accessing behavioral health services. And so I think that was part of the motivation to start this.
It is. I couldn't figure out how to unmute myself. Sorry.
Oh, no worries.
I'm on my phone. Yes, and she is exactly right. I'm sorry. I just figured.
And I think you're on mute now.
Oh, I'm back muted. Okay, now I'm unmuted. Good. I just figured out how to do that. It's a different deal on my phone here, and I'm having to be on my phone because I'm traveling today too. We are looking to do this. We had started doing some work with social workers 2 or 3 years ago with a group that helped us first with identifying social determinants of health when that became a phrase, and we needed to do that. We did identify those. Then we needed to know what to do with some of those, and so we did that on a grant. We got another grant to both continue that work and look to try to find resources for our patients, and in our hospital side to do some case management to help people that are leaving the hospital with some of those. With a social worker to do that instead of a nurse. Nurses do great care, but they don't necessarily do good social work care. Social workers do better social work care. So we are really looking forward to this. I am, if you can name a social worker in Southeast Arkansas below Pine Bluff, you're doing better than me because I cannot. We have got one that comes here and from the group that we work with, actually a couple now. So it's just really been terrific, and we are ramping up for BHI to make a big difference in our clinic. Our primary care doctors, sometimes, primary care doctors are hard to get on board, but they are very on board for this.
That's awesome.
People too. We're just so excited here, and we can't wait to get down there. And I know your social workers are having to come from far away. At the conference, I had an opportunity to visit with Melrita, and I know she lives in Little Rock, and I think another one said they lived in Mississippi.
She lives in Mississippi. Yeah, we have one that comes down from Pine Bluff, but like I said, it's very difficult to find somebody. We get some face to face. We do a lot on telemed, which has been a real help for us.
That's awesome. Wow, we're excited, and we're excited for this virtual option for CoCM. That'll be a great addition. All right. Well, we'll be counting on you, Terry, to keep the group updated on how things are going. We want to hear successes, but we also want to hear challenges and pain points and things that we need to improve as we're rolling out this model. So we're excited.
Well, super. We are putting together our flow chart and everything right now for our meeting on the 14th, so we can present that to you and we can see what things look like.
Awesome. And we've also, I see Tucker's on with River Valley. Tucker, I don't know if you have any thoughts or anything you want to share with the group. I know, well, actually, first let me introduce. We have River Valley Medical Wellness, which is a family practice clinic, and they have sites in Russellville and Hot Springs. And they have Dr. Martin, who is their CEO and owner. And Dr. Martin is trained in family medicine, emergency medicine, and addiction medicine. So they have a lot going on in their practices. They also have, I think, 2 mobile units right now, have expanded to do some maternal health work. But I think you all, Tucker, have such a unique opportunity to really meet people who are struggling with substance use and these co-occurring disorders. So we're so glad you're on with us. I don't know if you want to add anything to this.
Kim, I don't think Tucker is on. If you're seeing his name, it might be his meeting notes that are on here.
Okay, no worries. Thank you, Kate. Yeah. I don't want to be talking into the void.
The spirit of Tucker is here though. He's very excited.
Yes, we're happy, so happy to have River Valley. And I was actually just on the phone with Dr. Martin right before this meeting, and they are, I know Teresa is on, and they are working on finalizing their contract with the Woven Doctors. And so the Woven Doctors are asking that we do that. They'd like us to do that prior to them coming. So I know Dr. Martin's working on it, and she'll be working on it this weekend. So that is in the works. But of course, without them, it's going to be extremely challenging to implement this model. So one thing that we are doing is we are working on a logo for this project. We have not completed that yet, but know that that's in the work. We've had a couple of iterations that we have edited and made updates to, so please know that is happening. And then I'm just going to ask Caitlin, do you see anyone from East Arkansas on?
I don't think so. Let me see. No, I don't see her. on today.
Okay. Well, I also, as part of this update, I wanted to ask Dr. Gibson. I know she's been on some, a lot, not some, she's been on a lot of national meetings, and she's been attending some webinars where I think she's gotten some good information. I don't know, Dr. Gibson, if you'd be willing to share some of what you find that's happening nationally with CoCM.
Sure. Can y'all see my screen that has National Council?
And
I
now,
think it's still trying to pull up.
There it is.
There we
Yeah.
go.
There we have it.
All right. So a couple things. One, it's almost like there's so much news happening around people releasing papers on CoCM. I mean, traditionally, or a lot of the randomized controlled trials have been focused on anxiety and depression, but we're seeing more and more where they're using CoCM in various populations, including, as we were talking about River Valley, in substance abuse populations, in maternal health populations, pediatric populations. And the National Council for Mental Wellbeing will be having this conference on August 26th, where they'll be talking about scaling up CoCM for serious mental illness and opioid use disorder. And Anna Ratliff and Dr. Thomas will be, Jen Thomas will be talking about that. So it's really showing the widespread potential use for collaborative care management as a way to access mental health care for various populations. And it's not just restricted to the anxiety and depression population, but there are parts to that in terms of it's important to figure out what your population is and to implement it very intentionally and carefully as a to be sure that you're going to meet the needs of the population that you're trying to serve. We just heard Terry talking about how hard it is to get social workers and why they're leaning toward this. And then we keep hearing about how the access to mental health care is a huge issue. And this is a slide that we continue to show, showing that of people who need mental health care, only 4 out of 10 are going to get mental health care, and 2 of those are going to be by the primary care doctor, and only 2 will end up going to a mental health clinic. At least 60% of the people don't get any care. Well, recently we looked at some data with one of the mental health clinics in Arkansas, who we were really focused on getting some of our patients' care into this community mental health center. And what we saw, and you can see the timeline on the bottom, and then going up from 100 to 600 is how many days it was to the next visit. So we got patients into the clinic, and you'll see that in January of 2023, it took an average of 116 days for those patients to get back to the mental health clinic. And so that really supports the what we've seen way back to 2005. There's a no-show rate to mental health clinics, and people just do not engage in going to mental health clinic. So that is a huge reason for the utilization of mental health, of collaborative care management and integrated care. But just this is recent data that we've gotten from some of our Blue Cross claims showing that actually the average is going up, that is 300 days till their next appointment. The next thing I wanted to share, at a recent CFHA Collaborative Care Management Special Interest Group, we had speakers from the Bowman Family Foundation. So we want to be sure that people are aware of this as a resource. and this is just a screenshot from their website, that they are very much about access to mental health and providing research and studies to show how we can improve this. They're talking about mental health parity, network adequacy, and it really caught my attention in their recent, when he was doing his presentation for CFHA, that CoCM can be a way to increase access to mental health care and to help employers and groups to be compliant with the mental health parity laws. And so looking into, wanted to share this is, and we'll share these links, but the mental health parity laws require that any type of insurance or employer that's providing insurance has to be sure that their mental health access is no more restrictive than the access to physical health care. And so there are federal laws, state laws about mental health parity. And in January, the federal government, the departments that actually audited various plans, released this really long report. But one of the things that was in the report, when they found some plans that were not in compliance with the mental health parity laws, they this particular one, this is an example of a settlement agreement with a plan where the plan was actually asked to identify collaborative care model providers as a part of their mental health network. So this is a really big place where collaborative care management is being actually implemented and asked to be implemented through federal regulations and eventually through possibly through state regulations. So wanted to share this, that this has actually showed a settlement between this federal government and the this is actually the Boilermakers National Health and Welfare Fund, and it showed that their network was not adequate. And one of the ways that they could show that they would have an adequate network was to identify the collaborative care model providers that are available to their network. So that's news that we have not heard before, of utilizing primary care and integrated care, collaborative care management as a identified resource for network adequacy. So thanks to the Bowman Family Foundation for sharing that with us, and it being brought up with at the CFHA CoCM Special Interest Group. That's
Wow.
enough for me to focus on.
I was gonna say, there's a lot going on, a lot happening. And I think you're bringing up a great point when I hear you say, every time I look, new articles are being released. We're hearing more and more information from National Council for Wellbeing. We're hearing, the Bowman Foundation, who is this really big advocate and is looking at and researching how effective CoCM is. And then we're hearing, and we see our own CFHA, who is doing such a great job advocating. I just have to say, and I don't know, I'm sure you remember, and Tisha, I'm sure you probably remember, but this was probably maybe 4 years ago. We were at the CFHA conference, and we went to the meeting for people who are interested and involved in CoCM. And I'd say there was maybe a handful of people, and now when you look at, the amount of interest in people who are starting to attend, there's easily 30, 40, 50 people every time. So it's growing so much. And for me, it's so encouraging because we're seeing the workforce who's now really interested in, how do I learn how to do this? And the physicians who are saying, gosh, this sounds like a great idea. I want to try it. And we're seeing um, lots of this. I don't know if you've noticed as well, Dr. Gibson.
Yeah, one of the things about the CFHA is that it's one of the few organizations that has people from various disciplines, whether it be from primary care, psychiatry, therapists, social workers. And so that's one of the great things about the Collaborative Family Healthcare Association that we don't see at other places, as this is a place to get connection to other people that are also trying to do the same thing we are. I'm putting a link to the conference that'll be this October 16th through 18th in Raleigh, North Carolina, where we can connect with other folks who are doing not only collaborative care, but also co-located or primary care behavioral health, PCBH.
Absolutely. Anyone have any questions or thoughts on any of the information Dr. Gibson shared? All right. Do we have anybody from East Arkansas on? No. So we don't have anyone from East Arkansas, but just give a quick update. They have hired their second behavioral health care manager, and she started July 14th. Oh, my memory's better than I thought. And we have been virtually training her, and she is getting up and running. And they have approximately 85 active patients. She really hasn't started seeing patients yet, but Kiara's been holding down the fort for East Arkansas and really doing such an amazing job. My apologies, someone's going to die with it's probably really noisy. Just wanted to say that East Arkansas is going to try to start launching into West Helena in September. So that's really exciting, bringing on those additional sites. Amanda, I don't know if you have exact numbers. I don't have their numbers up in front of me. I know we talked about them last Monday.
I went through the notes yesterday, and it looks like East Arkansas has 97 patients that they had from like February, and there's 72 active at this
Okay.
moment.
Awesome. Yay. So they discharged some.
Yes.
Yay.
And that is as of yesterday afternoon, but I think a few have come across this morning.
Okay.
I'm not sure where they're from. So
Thank you. All right. So I think that's our update. I just have to give a shout out to Teresa. I know you're on, Teresa. We've been working on that logo, sending it back and forth. I don't have the logos in front of me, but I don't know if you would want to, we could share the logos and if that's not possible, no worries. But just to know, Teresa and I have been working on that, and we hope to get a logo in the next couple of weeks.
Have to unmute. I apologize that I'm just on verbally, but yes, you all have been amazing helping us get that sorted out. It became clear that the project needed a little bit better identity than it has. And so we've developed a new logo, picked a name, and I needed I had to have some verbiage to go on the logo indicating that it was a SAMHSA project and worked with DHS, et cetera. So I finally have that taken care of, and I'll be sending that over actually. And then what we're hoping to do is kind of have a launch. We had always had an executive committee that met once a month, and it seemed like to me it wasn't really accomplishing a lot. So we're going to sort of relaunch that with a logo and very clear objectives for what we'll do at each meeting. And we're going to propose that instead of monthly meetings, they be quarterly and have a very clear focus for what the purpose of that meeting is. So, so we stepped back and kind of been working on revamping how we'll communicate to the project outside of the people that are working on it on a regular basis. So that we can, we can make a little bit more clarity about it. So, so anyway, did I cover everything you asked me for?
Yeah, no, that's great. And I think we're getting ready to near the end of year 2.
We are getting near the end of year 2. So, and the other thing we're doing that I thought I would share today is, I really appreciated Dr. Gibson's note she sent over that some places are finding that the patients don't stay engaged in collaborative care long enough to really fully benefit and get the desired outcomes. And so we're working on our record keeping to be able to tell who stays engaged, who kind of drops out early, that kind of thing. We aren't quite there yet. But we're working on getting that capability so that we can better understand, because we are recording outcomes, right? We interview the patients at baseline and then every 6 months or whenever they leave the program, but we're not necessarily recording, doing a good job of saying, oh, this one, was only in this long and this one. So we're trying to get at that a little bit better so we can look at outcomes and length of time people are in, that kind of thing. So
that's awesome.
So anyway, we're excited and we're excited about our new sites. And I'm increasingly excited that there is so much interest in, just nationwide, there seems to be much more interest in using collaborative care to treat persons with more serious mental health conditions and substance use. I appreciate the discussion of that today, because I think that's a wonderful way to get care to a lot of people that wouldn't otherwise think to access care. And one thing, when Dr. Gibson was talking, I didn't pipe up and say this, but when I was working in VA, we had some project that was doing qualitative interviews with veterans about why they did or didn't seek behavioral health care, especially for a specialty behavioral health care. And one of the things they said is kind of related to stigma. They said, well, it's a small town. If I go to a clinic that's only known for providing mental health care, then everybody in town sees my car and knows that I'm getting that care. But if people are just going to their primary care doctor in the primary care clinic, then that takes away one more barrier to getting mental health care. And so that just struck me today when Dr. Gibson mentioned that.
Teresa, this is Terry Amstutz. I had a psychiatrist one time who worked in one of my clinics, and he told me that all of his patients came from the next town, and the psychiatrist in the next town, all of his patients came from our town, just for that very reason.
Yep, I'm not a bit surprised. And you know, despite a lot of efforts, there continues to be kind of this stigma around getting mental health care, and or really thing to say is behavioral health care, right? But anyway, I'm excited. That's one of the reasons I'm excited to see some uptake for using this model for a wider range of behavioral health needs. I think that's everything I have, other than I appreciate everything ABIN does to facilitate implementation of this model. I keep telling Kim there's actually an official name for what she does, which is implementation facilitation.
So, hey, it's Vern. I'm sorry that I was late today. I'm joining the conversation late, but Concert actually has launched PTSD and bipolar care in collaborative care in Arkansas with Mercy. That's going really well, and we're seeing some really good outcomes using the PMQ and the PHQ for bipolar and the PCL for trauma. So super exciting to sort of hear this conversation and you know, what sort of the trend is, and to just let people know to add on to sort of what you're talking about.
Erna, I'm curious, where have you started to do that? Which sites in
All of them.
Oh, wow. Okay.
Go big or go home.
I love it.
That's the motto. That's the motto. Yeah, in all of them. In fact, there's 160 practices in total rolled into the project. Yeah, yeah. And so we're now it's out, and yeah, but in all of the Mercy practices in Arkansas, absolutely, yeah. And Oklahoma, Arkansas, and Missouri. But in all of our practices, it's in 22 states total. Yeah. Mm-hmm. Oh, you're on mute again, Kim.
I'm curious, could you talk a little bit about the care team buy-in? Have you been having any challenges, or how has that been going?
Yeah, I think actually a couple of things. It was really the care managers love it because they're like, oh, now we're actually really paying attention to trauma. It isn't like we're doing the anxiety scale and we're treating trauma. Like now they can kind of fold it all together. The primary care providers have really liked the ability to get some extra consultation to say, here's how I think about prescribing differently for someone with PTSD versus anxiety. A lot of them were sort of putting everybody in the same bucket. And the bipolar, interestingly, there's a cohort of providers who are already prescribing and actually loved the consultation to say, oh, I wasn't quite getting it right, or, and then what we've also done is we've put in a confirmatory visit. So if there's a provider and they're like, I am not going to prescribe for bipolar, it feels a little out of my wheelhouse, we actually have a psychiatric, one-time psychiatric confirmatory consultation that can happen remotely with a psychiatric provider. And then that information goes to the PCP, and then they can decide if they're comfortable prescribing or not. And if they are, then they stay in collaborative care. But that confirmatory visit has actually been really helpful for some of those providers. And for bipolar patients, really it's about support, right? Wrapping a tight blanket around them, and medication support, and education and information. And so it's really been helpful for them because many of them were not getting the right care. So lots of fun. Yeah.
Cool things happening with Mercy in Arkansas. That's awesome. Thank you for sharing, Vernon. Anyone have any questions about that project or questions for Verna?
Right before you got on, Verna, Teresa was making a comment that they were looking at UAMS at engagement in collaborative care management. And we have been seeing that in some other states that have had systematic collaborative care management. And so I know that y'all published a study on factors that lead to more engagement.
Yeah, you sent me that text and I was looking for it. Oh,
Is that it?
Found it. It just came out the other day. Yeah, factors relating to patient disengagement. Yeah. So I can tell you what we found, and over 120,000, and actually looking at some other data. It's not the amount of time, it's the number of contacts. It's that number of touches that is the greatest predictor of outcomes and engagement. So the patient that gets, 5 visits, for 35 or 45 minutes, or the patient that gets 10 5-minute touches, the patient that gets 10 5-minute touches is going to do way better, have better outcomes and engage better, particularly in the first 2 weeks and in the first month of treatment. And so we see that over and over again, which I think just makes the most sense. And for me, we used to call it front loading when collaborative care first started. And that's because we knew that patients that had a treatment success right away, like we set a goal, we're gonna, see if our shoes are in the closet, and then we celebrate that goal. We met it. What was it like to meet your first goal, to really celebrate it? If people have that early win, then they are way more likely. So it's about the number of contacts, and it's about that short-term, really achievable goal, like right in the first week of treatment.
I think that's really relevant because a lot of times people get very prescriptive about wanting to say, we're going to see them at XYZ time periods instead of individually what the person needs.
And that's the whole magic of collaborative care. Like a lot of times people say to me, oh, well, we see people every other week. And then I'm like, well, you're not doing collaborative care, because that's all I need to know. I don't need to know anything past that. And so, yeah, that's the magic of collaborative care, is sort of everybody being very patient-centered and having sort of those different times. Yeah.
Any other questions for Verna on engagement or any of those pieces? So Verna, I have to say, as I'm listening to you, you're constantly in my mind. I think of you and think of all of the wonderful advice and wisdom you have about CM. And when I hear you talk about initial high touch, it's engaging them and capturing them.
Yeah.
Having wins, having enthusiasm, being excited, and that becomes contagious. People want to continue.
It does, like I'm going to go outside. And that's why the telephonic piece is so important in collaborative care. Well, my goal is to go outside. Let's go outside right now. Take a deep breath. What do you see? What's the weather's like? How does the sun feel? What do you see? Like that you actually go through that with them. And man, is that empowering. What else do you think you might be able to do today or tomorrow? Let me give you a call back and see how it went. And that's such a dramatically different experience for them. They're way more likely to complete that goal. They're way more likely to pick up the call tomorrow, and they're way more likely to engage in care and get better. So yeah, I mean, you're absolutely right. That's what makes the most fun.
That's awesome.
Yeah. Also, I don't know, I've spent a lot of time recently reading the CMS proposed rules. And so I don't know if you've had that conversation, but I would be more than happy to answer any questions that people have about that. And they may have none, which is fine.
I think that's such a great point, and I'm so glad you're bringing that up, Verna. I know I was just looking at the MLN and all of the red changes, right, that are coming in January. I don't know if you would want to give us kind of a high level overview, or if people have questions.
I'm glad to do either.
Maybe a high level overview would start us off. That would be wonderful. Thank you.
Sure. There's a couple of proposed changes that we actually sent that we're kind of hopeful about. The first is that right now the language in the MLN is that only the primary care provider, the billing provider, can get consent, and that would transition to anyone on the care team. That language would be more intentional and not just primary care, but also include specialty. And the language that's kind of been hanging in there around psychiatric consultation weekly, changing that to that it be available, so that it reads a little bit differently there. Probably the biggest change that we really expect is for the FQHCs, and that G0512 code will be going away. And they will be able to use the CPT codes. I think this is a huge deal and actually a win for folks. And then for those sites that are advanced primary care, the codes are going to get added into advanced primary care. What they're going to look like has been the subject of much debate. What we think will happen, maybe, is that there will be codes and then you'll get paid based on medical, on complexity modifiers. So there won't just be one rate, but they are getting added to the advanced primary care. And we also have been strongly advocating for the mid-level provider payment disparity to go away, since the costs are fixed in collaborative care for the components. And so a nurse practitioner would get reimbursed the same as an MD for collaborative care. So those are some of the things that are out there that we're thinking about. There's some others, but that's a little bit of a summary.
That's really exciting. I have to say, we are working with a large FQHC in Arkansas, and as you start to think about billing, of course, the codes that we currently have, it's been challenging. And so to hear that they could bill CPT codes, I think is going to be huge.
Yeah. And also the Complete Care Act to pass would mean dramatically increased reimbursement for collaborative care.
Oh, wow. Other questions for Verna while we have her, while she's here?
Glad you popped in.
I was gonna say, we have a quiet group today, and that's
I
not
know.
usual.
Well, it seems like everybody's traveling. I mean, I don't know if everybody coordinated that, but it seems like everybody's going somewhere.
Yes. I just have to say, this is really exciting. I know it's August, but January 1st will be here right around the corner. And as you're talking, Verna, I'm thinking maybe we could have you come and, I don't know, talk for 15-ish minutes or so, giving a formal update in this group before the 1st. Would you be willing to do that?
Yeah, I think that's completely fine. I would also say if people
You're on mute.
Yeah, and what
Sorry.
happened? It sort of auto did it. What I would say is that if there's organizations that want to get added to advocacy, so like if you're an FQHC, let me know, because then I could add you on to the advocacy just to support the change to get rid of the G code and some things like that. So, but yeah, certainly, however I can be helpful, I am all about the spread of collaborative care. So
We love that. And thank you for all that you do give and share, and it's invaluable. Okay. I'm watching the clock. I know I don't think we have DHS on. But Tisha, do we have Tisha on?
No, she's at a conference.
Okay. No worries. We got to hear a little bit from Teresa about things that are happening with the project. And I know we'll be starting year 2 right as we'll start year 2 in October, and then we'll have these new CMS guidelines. So really excited. Teresa, I just want to give you an opportunity to see if there's anything else that you wanted to add. And if not, we will turn it over to Caitlin. And Caitlin, you can give us some updates about things that are happening.
Sorry.
Oh yeah, Teresa, sorry.
And I wondered why nobody heard me. I put that mute should go off, but it didn't. I just wanted to clarify, a minute ago you said we would start year 2. We're starting year 3.
Year 3. Thank you.
Yeah, we're starting year 3, and then UAMS has put collaborative care in place in 5 clinics, but I don't know when they last reported here, so they may have already told you that they were in 5 clinics. And that's really, I don't think there's any new. We haven't heard any particular, check with the regularly to see if there's any change to the grant or anything that they're hearing from SAMHSA. Have not heard, they said no, they're really not getting anything. So that's where we are. But
Okay,
we're excited.
awesome. Well, we appreciate you. Okay, Caitlin, if you want to give us any updates about what's happening as far as training and resource.
And just like always, if you guys have something that I'm not talking about or don't know about, please jump in here. And I don't want to take Michael's thunder, but if he wants to talk about it, but they are doing, UAMS is doing a women's mental health forum. Do you want to talk about it a little bit, Michael?
Sure, be happy to. We're excited to host this. It's going to be a very unique format for us, and the fact that there are going to be workshops for people to attend. We're going to build on what we've done before with our different TED Talks. We're having in Matt Boone. Our own Matt Boone is working with Dr. Jennifer Gregg on they have a couple of books out on acceptance and commitment therapy. And so that's not the specific point, but that kind of plays in the background of what they're doing. Then we will have 3 presentations, one from Dr. Kylie Jones, who will be speaking on teen girls, social media, and growing up confident. We'll also have a presentation from Dr. Erin Jefferson, who's part of our women's mental health clinic at our new location up in Fayetteville, who will be speaking about the mind and motherhood. I don't know. I think my mother said that I helped her lose her mind when she was raising me as a kid. So that's not a part of this. So, and then our own Dr. Laura Dunn is going to be speaking on aging with grace. We're going to have some workshops that will also be interesting. And the fact that we're going to have a cooking demonstration and a discussion on the mind-gut connection. We'll also have an additional discussion from Dr. Chelsea Wakefield on relationships and sex. So there. I was wondering how I was going to present that, and I thought, well, I'm just going to say what it is. And then we will also have a panel discussion from some people that are involved in different community groups that are working in support of women's mental health. Ashley Bearden with the Arkansans for Mental Health, our maternal health improvement will be there. We will also have Shauna Ray Griffin, who will be one of our physicians who will be moderating, and other representatives that are going to be there whose names have just slipped my mind. So it's going to be a great day. It starts at 8 a.m. and ends at 2, and we look forward to having you there.
I can't believe that's all in one day.
All in one day.
But I believe you can pull it off. Anything, I'll say confidently, anything that UAMS puts out there for educational opportunities is really good. And Matt Boone is a big deal in the social work world, so we're excited to see him presenting.
Yeah. He takes a good picture too on top of that. So
yeah. So, and I do have to brag on UAMS and Children's a little bit. I went to the school-based mental health symposium last week, I think, or the week before, the end of July, because I don't know time. But that was a phenomenal conference as well. I don't work with children very much, and I feel like I learned a lot of stuff in just one day. And I appreciated the online opportunity too the next day. So I just wanted to say that they have a proven track record of having fantastic conferences. So I definitely would jump on this. And I think, you know, women's health is a hot topic and a needed topic, especially here in Arkansas with some of the statistics that just came out around maternal health. So I think it is going to be a great time, and thank you guys for hosting that. And Michael did say that the flyer is coming. So you can, this link will be sent out with the follow-up notes from today, but there'll also be a flyer that we spread on some of our social media as well in the coming weeks. Okay, upcoming, I hope that changed. I'm not sure if my tabs change when I'm on here. But there is the Arkansas Council for Behavioral Health is hosting the annual Arkansas Behavioral Health Institute in Hot Springs this month from the 26th to the 28th. Kim and I are presenting on a couple of things. They were gracious enough to allow us to talk to folks about CoCM. And then we'll also be doing a presentation on youth expert. So if you are in the area or you plan on coming, feel free to stop by and say hello to us. But it's 3 days worth of or 2 days worth of a lot of good information. There's what I saw on the agenda, a broad spectrum of topics. So it's always a good time when we go down there, and Hot Springs is a fun place to be. So that is coming up. And then just as far as our own resources for AVEN, I just wanted to send out or just give everybody a reminder that our YouTube does exist, and it does have playlists from our conference. We've had a couple of people ask to get in contact with some of the speakers from our conference. And if there are anyone that had missed it or maybe wants to replay one of those presentations, we do have a playlist available on our YouTube channel that you can listen to all of those on. In addition to that, we do run a CoCM resource page on our main website. It has all kinds of information on it. And I do have to give a shout out to Misty because she designed a lot of this and put a lot of hard work into it. So you're able to go into one place and see education on the model. And we also have a lot of our CoCM related webinars on one tab here. So that's available. And then finally, our monthly AVEN webinar for August is on the 14th from 8 to 9. And if you like hearing me and Kim talk, here's another opportunity to do so. We are going to present on youth expert and provide tools and strategies to implement that into some of your clinical care. That is worth one free CEU. So if you're looking for some, feel free to join us. And that's always how it is for our AVEN webinars on the second Thursday of the month. So throwing a lot of information out there. If you guys have any questions, feel free to email me or Misty or, of course, Kim, and we should be sending out these links soon after the meeting. Did I miss anything? Anything else?
No, sounds great. Thank you, Caitlin. All right. Well, I know we're at the top of the hour, so I just want to say thank you all for your patience with me today. My apologies for any background noise. We appreciate all your support, and we are so excited to see the growth of CoCM in Arkansas. We've got this grant who's doing amazing things, and then we've got Verna and the Mercy system, and so excited to continue to hear from Mercy and watch all the things that are happening with CoCM. Thank you guys. Have a great week. Bye-bye.
Good to see everybody.